No, so I do a decent amount of hemicondyle transplants for cartilage defects, and I've done everything from microfracture behind those grafts into the cancellous bone to bone grafting with other products. I think this would be a good area to sort of look at. I just haven't had a personal experience with doing that yet. So, question comes in from the audience, and maybe Gil might be best at answering this or not. But they said, how do you think the results are going to compare to Infuse? And Infuse, again, is a graft that's rich in BMP and goes in with a carrier sponge. It's typically used in spine, so it's not something that I have much experience with. Gil, have you seen it used at all, or?
Yeah, yeah. So, like I said, about 13, 15 years ago, I was a very heavy Infuse user, primarily for open tibia fractures, as the previous kind of randomized prospective studies showed advantage over autologous bone grafting. And so the challenges we saw, and it subsequently kind of came through in other publications after the fact, were that you tended to see a few things. You had this hyperemic response, and it often mimicked infection. And so, albeit that was recognized and we kind of watched some, but others were just so close to mimicking infection that we would have to do, operative debridements. And then with that, then essentially you lose the Infuse. And so that's one comparison. I've not seen that with the NanoBone occur at all. So I think that's one major difference. I think from the perspective of bone healing that we had seen, at least with just using the Infuse in tibial defects, there were cases that I had to go back that needed a subsequent autologous bone graft because they didn't heal. And so I think that's when I started shifting for the tibias, at least 13, 15 years ago, from using the Infuse BMPs to back to just autologous bone graft because, I didn't like the fact that I was seeing potential infection risk, tissue risk, non-unions subsequent to that. So that was another difference. So the third thing too, obviously is cost. And I think that has some variability, but to my understanding, I think the cost of the NanoBone is less than the Infuse. And so I think maybe that can be clarified by our ARTUS folks. So, but I think that is, for me at least, the third big difference. And so again, I haven't used the Infuse in many years, but at least when I was using it, those were some of the issues we had. And so that's probably the input I have. But, if I were to logically state, and I could extrapolate cases from way back then and then compare them to cases I've done now, I would say that data would show just an earlier healing response clinically and radiographically.
Yeah, I agree. Just
Bill, this is
right, two different concepts, right? Because Infuse is going to be osteo-inductive, and this is an osteoconductive material. So also comparing apples and oranges.
Yeah, just to address the question about cost, NanoBone is typically about half the cost on a volume basis of the Infuse.
So question comes in from the audience, again, for the entire panel. Any experience looking at this with osteoporotic bone? And if so, do you think that, the combination of the molecules involved with the NanoBone are going to allow for improved healing and improved stability on those fractures?
Yeah, I'll take that. Yeah, I mean, I think the answer will probably be yes. And the reason being, if you look at some of the products that kind of help promote bone healing, like a Forteo, again, it's apples and oranges, I get it. But if you were to utilize that in the bone healing cascade, meaning you have a fracture, you have osteoporosis, I'll use a distal femur for us in our geriatric population, or especially our population that has kidney disease, high risk of non-union to begin with from the time of their injury. Those are probably cases that I will probably start utilizing it more. I don't know the answer about osteoporosis, but I would think intuitively it might make sense. I don't know what the evidence shows in a lab as far as improving the osteoporotic model, but it may well be. I don't have access to that information offhand.
So Scott and Gail and Rob, I'm not sure your experience with bone stimulators for bad fractures or delayed healing. Has this changed, or do you think it'll change your need for bone stimulation based upon the healing, or it's still too soon to tell?
It's certainly changed to me. Like I don't do a lot of fracture stuff, but my osteotomy they usually heal pretty well, but occasionally I've had to use a bone stimulator on them. I've used a bone stimulator on osteochondral allograft that took longer to heal. So I can see if I can do that, but I've found that these osteotomies are healing so much quicker with this that I haven't really used it at all.
Sean, my only experience, I have used it in an osteotomy before, at least so, obviously in that end of one equals, I have not had to use a bone stimulator, but my hope would be if we get the clinical results that are matching Scott and Gill's, at least on the early run, potentially we can minimize or decrease the utilization on that platform. And I think that's kind of up in the air based on the data kind of is going to be coming.
Gotcha. So, looking forward, Scott, Nirav, Gil, obviously, the product's newer. You've all got some experience with it. Things that you're going to be looking for, 3 years out, 5 years out, is there any concern with heterotropic bone or any concern for your breakdown down the road because of the different chemical sort of component than we're used to with our typical bone grafting?
Forward.
I really think it's an advantage.
I was just going to say, Sean, my comfort level lies in the 400,000 cases done in Europe, and they've not seen that kind of complication, to be fair. So for me, I know it's a new technology, at least in the United States in the application process, but the literature is robust, as Gil alluded to. It's been there for over 10 years, and there's not even a single case report of having that kind of derivative taking place. I think that's why I asked Gil, is that's my comfort level too, not having potentially a cortical window or something, being comfortable in the setting of not encapsulating nerves or vessels. I know in the spine world, Infuse had a concern, obviously, in the anterior cervical disc region. So I think that's my logic.
Gotcha. Thanks, Nirav. Gil, any thoughts on your end?
Yeah, I feel the same. I think as you, like anything, you learn about it, more publications come forward, your experience with it increases, that you kind of expand its indications on its own. For me, at least, it's still the kind of open defects, non-unions, but certainly looking at the advantages it may have in other models are kind of the next stepping stone, I think.
Scott, on your end, any closing thoughts? Someone who's maybe new to NanoBone, or I can tell you on my end, there's lots of grafts that are in my hospital already, so it's kind of tough to fight over. Do I want to use a different graft? Do I want to use a different rotator cuff anchor? Where do I pick my battles? What's some of your take-home points to someone who's thinking about giving this a shot and maybe needs to pitch it to the products committee?
So I think we've touched on a few of them, but one is just the tracking of allograft tissue. I think as surgeons, we don't really recognize all that goes into on the bone bank side and what they have to do and keeping track of all this tissue, worrying about expiration dates and those kinds of things, as well as finding room in your freezer. So I think that's a huge advantage. It can come on, it's shelf stable, various different sizes, very cost effective. It can go head to head. When you look at some of these spine cases, we didn't do any spine, but this is one of the greatest things in spine right now is, it's a standalone, it's the only standalone graft that's available for the spine. All the other ones, you got to put in all this other stuff to make it work. And this one, you just put it in there and it works. And to touch on your heterotopic ossification, I think the difference between this and some of the other osteoinductive material that can leach out into the tissues and promote that bone healing, this is well encapsulated into that silica gel, and that silica gel is basically reincorporated by the new ECM, so you don't really have that opportunity for all this material to be going everywhere in the whole body.
That's a great point. I can tell you, I did it HGO one time. Patient walked on a little too soon. I didn't have my normal grafting wedges that I wanted, and I put it in there what I could. And when I got the CAT scan, you could see everything's kind of squirted out to the side, my wedge, my cancellous wedge. And again, that's not the product's fault. That's simply, the patient being non-compliant. But I think something that's going to give me a little bit better stability at time zero or much earlier on in that cascade, as Gil alluded to earlier, is going to maybe prevent that from happening again. So, Gil, as a trauma guy, I'm assuming you guys have multiple different grafts available to you. Again, someone who's interested in this that maybe is using a different product, your take-home point is mainly the healing time to this or the handling. What's sort of your one thing that really drew you to this?
Yeah, I mean, I think it's the healing time, and I think it's the safety, the efficacy of the product, and it's, its wide use already in Europe. And, you know, the equally important, I think, is the cost. I mean, you look at a lot of the costs of BMPs, and, you know, surgeons who might be typically use a BMP and an allograft or cancellous chips, all that cost adds up. And as was mentioned, the significant decrease in that cost, I think, is important. And so in some circumstances, particularly doing them in a center that is cost sensitive, like our hospital system and our ASCs, I think that is a major factor. If you have the ability for early clinical and radiographic healing, lower complications, as well as a lower cost, then it's almost a no-brainer. And so I think if somebody considering this, to look at those three key variables and when you're deciding to do a bone grafting for fracture, defect, non-union, or that those should really come to mind.
Oh, thanks. Guys, I want to thank you all for taking time out of your practices to sort of talk to us right now. Again, as a sports guy, I'm constantly learning from the trauma guys, and Scott and Narav, your experience is great with the product. If there's any questions, we direct everyone to the landing page that was provided to you. You'll be getting an email if you haven't already with more information about Artos. And again, guys, everyone be safe, and I'll talk to you soon.
Thanks, everybody. It was a great time. Look forward to the next one.
Thank you.
Thank you, everyone.
Take care.
Thanks a lot, everybody.